Hello, my name is James Littman. Today I'm going to be talking about a patient I have with congestive heart failure. So this patient's initials are KS. She is a 58-year-old female. She is divorced, living with her daughter currently. She is on disability due to her chronic health issues. She presented to the ED in this case with shortness of air, swelling in her legs, generalized weakness and fatigue, and she had had a cough for about a week. Her past medical history includes diabetes type 2, obesity, asthma, an ejection fraction of 25%, ICD, hyperlipidemia, hypertension, chronic kidney disease. She's a former smoker. She has osteoarthritis, and she has a HeartMate 2 LVAD. Previously, she's had surgeries, including hysterectomy, cholecystectomy, and then the LVAD. Family history, mother and father both with diabetes and hypertension. Father also had an MI. Vital signs on admission: blood pressure 97/75, heart rate 116, respiratory rate of 26, temperature was 98.7, and satting 92% on 2 liters nasal cannula. She's a full code, allergies to erythromycin and amoxicillin. Physical exam, alert and oriented times 4. She was Perla at 3. Lung sounds were diminished. She had crackles in the bases, shallow breathing, poor skin turgor, weak pulses, which also could be due to the LVAD. Trace edema in the abdomen, but +2 edema in the lower extremities. Sinus tach on the monitor with occasional PVCs. Medication-wise, just on 81 milligrams of aspirin, 4 milligrams of Coumadin, Protonix 40 milligrams, and metoprolol 12.5 milligrams twice a day. A little bit about the pathophysiology of congestive heart failure. Congestive heart failure, it can be acute or chronic. In the acute heart failure stage, symptoms appear suddenly, kind of go away fairly quickly. This condition often occurs after like a heart attack. And then in chronic heart failure, which is what this patient's suffering from, symptoms are continuous, don't really improve much over time. And that's what the vast majority of these heart failure cases are chronic. So in heart failure, the main pumping chambers of your heart, which are the ventricles, they can become stiff and not fill properly between beats. And then in other cases, the heart muscle becomes damaged and weakened. And so those ventricles actually dilate to the point to where the heart can't pump that blood efficiently throughout the body. So over time, the heart can't keep up with the demand of perfusing the entire body. Heart failure can occur in either the left or right side or both, and it's also classified as either diastolic or systolic. Left-sided heart failure, that's the most common type. That's what this patient has, and that occurs when the left ventricle doesn't pump properly. So it prevents your body from getting that oxygen-rich blood that it needs. And the blood instead backs up into the lungs, making it hard to breathe. That shortness of air that she's exhibiting, and also the fluid overload, the buildup of fluid. Right-sided heart failure, that occurs when the right side of the heart can't perform effectively. And it's usually triggered by that left-sided heart failure, whereas the accumulation of blood in the lungs caused by the left-sided heart failure puts the stress on the right side to work harder, and it causes it to fail. And according to the Journal of Clinical Medicine, right-sided heart failure is marked by swelling of the lower extremities caused by fluid backup in the legs, feet, and the abdomen. And KS, this patient, exhibits those symptoms as well. So diastolic and systolic. Diastolic heart failure, that occurs when the heart muscle becomes stiffer than normal, usually caused from heart disease, and that's known as diastolic dysfunction, leads to a lack of blood flow to the rest of your bodily organs. Systolic or systolic dysfunction, that occurs when the heart muscle loses its ability to contract, which is important because it has to contract to pump that blood throughout the body. Some risk factors for CHF: high blood pressure, coronary artery disease, heart attack, and then a couple of underlying things that my patient had: diabetes and obesity, along with tobacco use are risk factors as well. A couple other modifiable risk factors: diet and exercise, along with alcohol use, can lead to CHF. Some diagnostic tests used for congestive heart failure. The most effective way to diagnose heart failure is through an echocardiogram. So that's going to use sound waves to produce a video image of your heart, and that test can help doctors see the size, the shape of your heart, if there's any abnormalities. It also measures your ejection fraction, which is used to help classify heart failure, and it's helped to guide treatment. So ejection fraction basically is that measurement of the percentage of blood that leaves your heart, that's pumped out of your heart every time it contracts, every time it beats. So when your heart contracts, it ejects blood from both the ventricles, and then when it relaxes, the ventricles refill with blood. An EF of greater 55% or greater is considered normal. Anything 50% or less is considered reduced. So my patient definitely with a 25% EF falls under the reduced category. A couple other diagnostic tests used: CAT scans, MRIs, chest X-rays, EKGs, electrocardiograms, stress test. And then you start getting into the more invasive type diagnostic tests, which include the coronary angiogram, which takes a flexible catheter, kind of guided through your blood vessels to your aorta, measures the blood that's being pumped throughout your body. They can also do a myocardial biopsy, which is taking a small little muscle or tissue sample from your heart, sending that off to see if there's any issues there. Treatment-wise, treating underlying causes, of course, can be one thing that doctors use to help correct heart failure. For example, repairing like a heart valve, or like controlling a fast rhythm that could damage your heart. For most people, the treatment is a balance of the right medications, and in this case, it is using a device to help the heart beat and contract properly. So it all depends on the severity of the condition. The main goal of the treatment, however, is to increase the lifespan of the patient. So like I said, the right balance of medications, use of diuretics, beta blockers, and vasodilators are huge. And my patient is on the beta blocker. Of course, when she was admitted into the hospital, we did give her Lasix to try and get that fluid off. And then there is surgery, and some people need that. My patient had the LVAD, which there's a bridge to transplant, so they insert the LVADs in order to keep that patient alive long enough for a heart donor. There's also destination, which is what my patient has, and she'll live with this LVAD for the rest of her life due to her underlying conditions. She is not a candidate for surgery. She's very non-compliant, so that's going to be her best that she gets. So the VAD basically is just an implantable mechanical device that helps pump blood from the chambers. It's implanted into the abdomen or chest and attached to the heart. So the outcome, the patient was discharged home with outpatient cardiac rehab and outpatient physical therapy, follow-up in 2 weeks, and then she has phone numbers to the LVAD coordinators if she needs anything in the meantime. Thank you.